Бурячок, 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 бурячок.
Орисія Стахівна, добрий вечір. Чи
Добрий
мене
вечір.
чути?
Чути.
Давайте спробуємо поділитися слайдами. Там внизу є ще.
Так. І сюди.
Так, ми бачимо ваш екран, поки що загружається. Так, але ми бачимо не як презентаційний варіант. Просто слайди вам треба зробити Presenter Mode.
Так.
Так, ми далі бачимо все рівно. Чи ви поділилися цілим екраном? Бо якщо ви поділилися тільки там презентацією чи якоюсь вкладкою, то воно так не покаже. Треба
Може. Так.
поділитись екраном. Ще раз зупиніть трансляцію і ще раз спробуйте поділитися цілим екраном. О, все добре, все ми бачимо. Так, супер.
Доброго вечора.
Бачимо перший слайд. Добрий вечір.
Ви зможете також поділитися пізніше. Я включу свої слайди, а потім ви знову їх завантажите. Так буде добре?
То мені зараз що зробити?
Стоп шерінг. Після інтро я попрошу вас знову завантажити, і ви знову це ж зробите, так? Буде так добре?
Це, так зробила?
Так, дякую.
Бери там є. Він може боятися. Інша Марина.
Леся, чи бачите мої слайди?
Завантажується.
Так.
Ще не бачимо.
Якось. Дякую.
Все, видно. На весь екран перший слайд.
Так, і вони також програються, так?
Поки що тільки перший. Наступного не бачу.
Там повинно бути відео, воно
І
активне.
треба ще раз клікнути.
Ага.
Поки що немає відео. О, все пішло. Угу. Все є.
Чудово.
Бери кріс. Сідай там.
Так, у нас ще є 5 хвилин.
Hello, Primoz.
Hi.
Nice to see
Hi,
you.
everyone. Hi, Lisa.
Hello.
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 То тут воно не добре, тут в мене все гаразд, а тут я не знаю.
We are waiting until 7 p.m. and we will start. Yeah.
Вже 2-3 хвилини.
Hello, everyone.
Hello.
Hi.
Hello.
Hello.
Прошу мене вільніше.
Доброго вечора, українські радіаційні онкологи, медичні фізики та радіаційні терапевтичні технологи. Дякуємо, що доєдналися до продовження нашого курсу Cervical Cancer Brachytherapy for Ukraine. Цей курс був організований Brachytherapy у співпраці з Help Ukraine Group, SweCare. Ми дуже вдячні їм за організований курс. Перед початком сьогоднішньої лекції я хотів би трохи нагадати, що у нас буде кілька живих лекцій. Одна з них сьогодні. Та більш детальніший розклад ви можете бачити зараз на екрані. Для того, щоб успішно завершити цей курс, вам необхідно пройти 100% асинхронних лекцій на платформі Brachytera, відвідати щонайменше 80% живих лекцій та скласти підсумковий тест з результатом більше 80%. Якщо ви ще не почали проходити ці лекції, то тут є коротка інструкція, як саме це зробити. Ви можете на сайті Brachytera піти до Go to Course і, відповідно, почати перегляд тих лекцій. Ви бачите статистику щодо сьогоднішнього нашого прогресу, тому я би дуже заохотив людей продовжувати вивчати брахітерапію, Cervical Brachytherapy і продовжувати навчатися на нашому курсі. Наша сьогоднішня лекція буде англійською мовою, тому, будь ласка, ви можете увімкнути субтитри для онлайн-перекладу. Я також перейду на англійську мову. So our lecture today is brachytherapy with 2D imaging, and our teacher today is Dr. Oresa Burak, and she is a radiation oncologist at Lviv Regional Oncology Center. She got her Doctor of Medicine from Danilo Haletsky Lviv State University in 2022, and later she also got her radiation oncologist from Shupik National Medical Academy of Postgraduate Education in 2025. She has more than 20 years of experience in radiation oncology and also in brachytherapy. She also practiced her medicine as a clinical researcher, so she participated in a phase 3 randomized double-blind study of pembrolizumab versus placebo in combination with or without radiotherapy for treatment of newly diagnosed high-risk endometrial cancer after surgery with curative intent, and in the randomized phase 3 double-blind study with chemotherapy with or without pembrolizumab for the treatment of high-risk locally advanced cervical cancer. She's an excellent lecturer. She is a trainer for many of her colleagues, and thank you very much for teaching us today. Dr. Burak, the floor is yours. You can share your screen and your slides.
Thank you. Я можу починати.
Yes, please. We can see your screen. One thing, please, can you set your language, speaking language as English?
Yes, I know. Yes. Okay.
Dr. Burak, if you want to speak Ukrainian, that's fine, because you will be speaking English just because of me and Christian.
No,
Um,
it's okay. It's okay.
Is it?
Yeah.
All right.
Thank you.
Thank you then.
In your captions, can you please set your speaking language as English? Because currently it's Ukrainian.
Can you please repeat wherever you can do it? In captions. Okay.
Will you see show captions or hide captions? There is a caret, my speaking language English.
Let me check. Sorry.
You see it?
Two.
somewhere in the settings, or let me check. La, la, la. Просто викладати. Oh, yeah. Yeah. Record presentation. Can you please tell us once more where we can?
Yeah, so in the bottom of the screen, there should be show captions. And then when you expand it, my speaking language English.
And the bottom.
Yes, the bottom of your screen.
Може тут? Uh,
If not, that's okay, I guess.
Oh, yeah, no, we will do it.
Okay.
Пані Орися, я вислала вам скрін екрану на телефон, гляньте.
Mhm. Yeah, I will stop sharing. Тут можу. Yeah.
Тут settings.
Show captions. Yeah. Yeah.
Yeah, you found it? Okay.
Yeah, just a second. We'll
Mhm.
find the language.
English.
Speaking language. Okay. Yes, we can see. English. Now should be okay.
Yes, yeah, great, excellent. Thank you.
Um, Okay, can you see the screen?
Yes, looks great.
Okay.
Okay.
So the screen is visible, yeah? You can see the slides.
Yes, everything is great. Thank you.
Завернутися. Dear colleagues, I would like to express my sincere gratitude to the course organizers for the opportunity to participate as an attendee and at the same time to present a clinical case of 2D brachytherapy. I would also like to extend special thanks to organizers and lecturers for their deep understanding of the challenges in providing high-quality treatment for patients with cervical cancer, as well as for developing educational resource for medical professionals and resource-limited countries. The opportunity for us to better understand modern treatment technology and to benefit from your experience in transitioning to innovative therapeutic techniques is truly invaluable. Brachytherapy represents a unique integration of radiation precision and technology, bringing together mathematics, physics, and medicine, and remains an essential component in the treatment of cervical cancer. Contemporary brachytherapy with 2D visualization is performed on system equipped with treatment planning software and imaging technologies. I would like to present clinical case. A patient, 41-year-old woman diagnosed with cervical cancer, stage 3, grade 2, pelvic lymphadenopathy was present. The patient also reported pelvic pain and had a history of scleroderma. Histopathology, squamous cell carcinoma of the cervix, SCC level 18.2, The patient presented with complaints of lower abdominal pain, bloody vaginal discharge, and joint pain following discontinuation of methotrexate therapy. She reported being symptomatic for approximately 6 months, beginning with mild to lower abdominal pain of a cramping nature, which worsened in the evening and was associated with pain during menstruation. Patient assessment. The cervix was deformed, dense, and immobile. The left parametrial tissue was infiltrated up to the pelvic wall with infiltration of the mesorectum. Tenderness on palpation. The uterine body was of normal size with limited mobility. Rectoscopy showed no signs of invasion into the rectum. CT imaging. Deformed cervix with a 25 millimeters hypodense lesion in the left posterior wall. Tumor extends to the vagina forming mesorectal fat and left mesorectal fascia. Adjacent to the rectum, no invasion. Mild left parametrial infiltration, and large lymph nodes, left external iliac 35-24-17 millimeters, proximal node near vessel crossing 27-14-29 millimeters. MRI imaging. MRI imaging, cervical cancer with stromal invasion, invasion into the left parametrium and left mesorectal fascia, left-sided pelvic lymphadenopathy. Patient had locally advanced cervical cancer with pelvic lymphadenopathy, no para-aortic lymphadenopathy. The standard of care is a combination of EBRT plus brachytherapy with concurrent chemotherapy. The EBRT treatment encompasses treatment to the pelvic lymph nodes, parametria, and primary tumor, to a dose adequate to control microscopic disease. Chemotherapy used predominantly as a radiosensitizer. As the addition of brachytherapy serves to provide the highest dose required to locally control cervical cancer. Previous treatment, completed course of EBRT, fraction dose 1.8 gray to the primary tumor and lymph nodes, total dose 45 gray, boost additional 5.4 gray to lymph nodes. Okay. Concomitant cisplatin, weekly 5 administration. Post-treatment assessment. Cervix uteri shortened, slightly deformed, uterus normal size, moderately mobile. Parametria slight fibrosis change, otherwise soft and free. Vagina, small area of infiltration on the left vaginal wall and the level of contact with the left cervical contour. A favorable therapeutic response was achieved with aggression of the tumor process. The patient is therefore planned for intracavitary high-dose rate brachytherapy. And despite the significant development of technology in radiation therapy, where it's possible to calculate the dose per tumor volume for brachytherapy as an exception under certain conditions, and CCN recommendation for dosing prescription regimen is 0.8, representing a paracervical reference point, has been the most widely used dosing parameter to date. Typical 0.8 prescription doses are 5.5 gray 5 fraction for early disease and 6 gray 5 fraction for large tumors or those demonstrating a poor response. The patient is scheduled for a course of intracavitary HDR brachytherapy with a fraction dose of 6 gray to a total dose of 30 gray. Treatment aim to deliver this prescribed dose to the point A while ensuring maximal protection of organs at risk, especially the bladder and rectum. Treatment system, HDR BIBIC multi-source system equipped with a cobalt-60 source. Treatment planning system, HDR plus planning system with imaging technology providing evaluation of isodose distribution, contours of organs at risk, and applicators. Automatic 3D reconstruction of applicators for visualization. Additional system function, dose monitoring for assessment of dose distribution, reporting function for generating treatment and planning reports, and X-ray system C-arm for visualization. Applicators type Fletcher. The use of X-ray allows you to see only the applicators and contours of organs and doesn't provide an image of tumor itself. To ensure stable dose distribution and minimize errors in brachytherapy, we use Manchester system and ICRU report 38. Manchester system use point AB, points bladder and rectum. ICRU report 38 was written regarding dose and volume specification and reporting of intracavitary brachytherapy in gynecology. In brachytherapy, method of dose specification are based on standard principle developed by early schools of brachytherapy in early 20th century. To ensure a stable dose distribution within the tumor and to minimize uncertainties, initially for low dose rate brachytherapy, Todd and Meredith developed the dosimetric Manchester system, founded on several Strangford principles. Treatment is defined in terms of dose delivery to a specific reference point. These reference points are anatomically consist across different patients. The points are relatively insensitive to small variation in applicator positioning. The system allows correlation between delivery dose and clinical outcomes. It ensures that the dose doesn't exceed tissue tolerance. SURM, the Manchester system describes point A and point B as the key reference point for dose specification. Later, the ICRU report 38 recommended a different approach. Instead of prescribing dose to a specific point, it proposed a system of dose specification that relates the dose distribution to the target volume. In this framework, the dose is prescribed as the value of an isodose surface that just surrounds the target volume. The report discourages the use of point A and point B because the exact meaning and definition haven't always been interpreted consistently across different centers. It encourages the use of target volume for dose prescription and reporting, along with the reference volume for 60 gray absorbed dose prescription. Importantly, this report is being revised and may include some dose points similar to the classical system. Brachytherapy procedure stage. After local anesthetic was administered, contrast was introduced into the bladder via Foley catheter. The contrast was introduced into the rectum. The length of uterine cavity was measured with a probe. Depending on the size of the tumor, angle of the uterine inclination, the length of the uterine cavity along the probe, and the vaginal wall, we select a certain type of tundra with the angle of inclination of central endostat and the dimension of lateral ovoids. Applicators were introduced. Applicator were introduced into the uterine cavity and lateral wall. Packing is formed. Packing is performed to pick the tandem geometry. Recobox was positioned over the pelvic area and the projection of inserted applicators. After that, X-ray imaging was performed into orthogonal projection. The image was transferred to the treatment planning system. The next stage is to create a treatment plan. And question.
Будь ласка, відповідайте на запитання, тому що ми так відстежуємо, чи ви присутні. Почекаємо ще на 80% відповіді. So we have 80% answering. Thank you for answering the poll. I'm ending the poll and sharing the result. So majority of you answered RCRU 50 and 43% answered RCRU 38. Would you like to comment, Dr. Burak?
No, it's for classical brachytherapy, we use the recommendation ICRU 38, but now for brachytherapy, we use recommendation ICRU 50. That's maybe, okay.
Okay, let's.
Thank you.
Okay. The geometry of applicator's placement is confirmed on orthogonal films. On this slide, we can see the contours of endostat and the points of the contour of the organs at risk displayed, which are aligned with the reco box for reconstruction. With 2D planning, the tumor itself and the organs at risk cannot be directly visualized. The doctor informed the physicist. The doctors informed the physicist the length of the uterus and cervix to set the length of active points where the source will move. The doctor also informs the physicist about the applicator type and number for selection from libraries in the treatment planning system. The next step after the specific parameters is a visual assessment of the shape that covers the tumor, dose delivery to point A and organs at risk. On this slide, you can see a pear-shaped coating of endostat and theraphoid tumor. This is a dose surface that is formed when the radiation of source moves a given distance in central tube and lateral ovoids. Length of the loading determines the height of the dose distribution and forms the narrow upper of the pier. The ovoid are positioned laterally. They border the dose distribution at the base, distribution radiation to the cervix and paracervical tissue. Distance between the two ovoids determines the width of the base. Therefore, before planning, we know the length of the uterus above 7 centimeters and the width of the cervix above 3 centimeters. These are individual patient parameters. Pear shape is dose surface covers cervix, uterus, and high-risk area for tumor spread. Also, each applicator parameter influences the geometry of irradiation, allowing treatment to be individualized. Changing the distance between the ovoids makes it possible to adapt the way of the dose distribution to the anatomy of vaginal wall. The size of ovoids change the curvature of the basal part of the dose distribution, helping to minimize radiation exposure to the bladder and rectum. Thus, the geometric parameters of applicators are an important tool for a personalized approach in brachytherapy, ensuring effective treatment while reducing the risk of complication, adjusting tandem loading effects and height of the dose distribution, and it used to cover more extensive uterine tumors. Modifying dwell times allows the center of the maximum dose to be shifted, optimizing the balance between effective tumor irradiation and sparing of organs at risk. This is our main task. On this slide, you can see, pear shape is a dose surface, 100% cover cervix, uterus, and high-risk area for tumor spread and avoid bladder and rectum. Yellow-green points. And dose monitoring. Following parameter definition, visual assessment of dose distribution is performed, including point A, mean dose correspond to the prescribed value 6 gray, organ at risk, bladder, observed mean 3.43 gray, rectum, observed mean 2.46 gray. The expected dose to organs at risk not exceed 18% of the dose in point A. A characteristic a pear shape is the dose distribution is observed, reflecting appropriate coverage of the cervix and surrounding tissues. Based on clinical examination and the measured distance between lateral applicators, adequate dose coverage of the cervix can be confirmed. This value This value are within acceptable limits. The treatment plan is approved and the patient is transferred to the treatment suite for procedure. 2D planning is performed primarily for each fraction. The patient completed 5 fractions with prescribed dose 6 gray to total dose 0.8 30 gray. Brachytherapy 2 times a week, overall treatment time 8 weeks. Post-treatment imaging, CT scan performed 2 months, demonstrate a significant reduction in the size of the cervical tumor and metastatic pelvic lymph nodes, indicating a favorable therapeutic response. SAC level 0.9, indication significant tumor market reduction. The patient is currently in general condition and reports overall clinical improvement. The patient is scheduled for chemotherapy, cisplatin, and paclitaxel. And question 2.
Thank you for your attendance and for answering the question. So we have 80% of participants answered the question.
I'm ending the poll and sharing the results. So majority of you, 76%, answered C, length of the uterine cavity and cervical canal along the probe. Dr. Burak, would you mind commenting? Яка правильна відповідь, доктор Бурак?
Це правильно. C is correct answer.
Okay, thank you.
Thank you. And summary, the 2D planning provides 2D planning brachytherapy provides effective localized tumor irradiation, especially small tumor, can be successfully combined with EBRT, 3D IMRT, and allows better control of radiation exposure dose to organs at risk. 2D brachytherapy remains an important treatment modality for cervical cancer, particularly in resource-limited countries. Thank you for your attention, and just wanted to say thank you to Professor Primož Perić for the lectures. It was genuinely great. Only regret is not coming across them some. Thank you.
Thank you, Dr. Burak. That's the last slide.
Yes.
That's great. So from cobalt to iridium.
From point to volume.
From point to volume. Okay, excellent.
Thank you. Do we have any questions from participants to Dr. Burak? I currently don't see any questions in the chat, but you can also turn on your mic and ask a question if you like.
Or maybe Primož or Christian have questions.
Yeah, maybe just short. Thank you very much for this very detailed presentation of this case, Dr. Burak, and I think it's a great introduction to the discussion about the possibilities, as you pointed out with the very last slide from point to volume, about the possibilities that relatively simple measures can bring in terms of improvement of brachytherapy for cervical cancer. And if you would add a CT in this process, how much can change in terms of our ability to adapt the dose to the actual patient, just like we do in IMRT or external beam, we can also do nowadays in brachytherapy to optimize the dose. And I think that the Brachythera platform with all the presentations, I hope, answers all those questions. And I think it's a very good sensitizer. The presentation that you made about those possibilities in principle, that we can move from points to volume nowadays. But I think maybe Christian can also comment from the physics perspective.
Yeah, I also think that you have really highlighted, on the one hand, the possibilities with two-dimensional brachytherapy, but also the limitations you have by that, because we don't see organs, we don't see targets directly. And I would also like to mention that one question I answered wrong, because I would have picked ICU 89 as the new standard. And maybe just to remind you that ICU 89 also has a chapter on radiograph-based planning. So it's not only MRI-based and not only CT-based. ICU 89 also includes possibilities with radiograph-based planning. Simple methods, point A, of course, is still there, but there are also ideas to take into account the dimensions of the cervix to the left and to the right, to do something better. And in my experience, I started very young, and we started also. When I see it at your images with the radiograph-based plans, I know this is also quite time-consuming, because you have to do the X-rays and then you have to reconstruct all those points. When we switched to CT, this was not that much more time, because for me as a physicist, it's even easier nowadays to reconstruct on CT, because it's very easy, very simple. You see your applicator inside, it's just 2-3 clicks, and with reconstructing, it takes much longer. So I just want to say that it's not, these new techniques are not only better in terms of optimization, but they can also reduce time in the end.
Excellent. Thank you. I would have a question to maybe Serhi and Dr. Burak about approximate statistics in Ukraine. Do you know how many centers are using 2D planning and how many use 3D approximately in percentage?
Yes, yes, please.
Okay, Serhi.
I think that 3D is used in less than, let's say, 5% of centers.
Mm-hmm.
And actually, the 2D planning and actually no imaging in brachytherapy is kind of 50% maybe.
Okay. No imaging at all. Mm-hmm.
Exactly.
So at least those centers that don't have an opportunity or possibility to do 3D imaging, they can at least acquire radiograph maybe using, Linux. Is that possible?
Well, Linux is quite busy with the patients, so I don't
see.
think it's possible from the workflow point of view.
Mm-hmm.
That would be.
What about ultrasound, Primoz? Is that the recommendation? At least some type of imaging.
Ultrasound will not get you there. It can give a lot of information, but it will be the advanced at the advanced end nowadays. Ultrasound will not get you there where you need to be, because it does not have the standard frame of reference in terms of imaging. You don't get this, like in prostate, for example, where you have the stepper and the fixed coordinate system in external beam. You don't have this in cervical cancer brachytherapy, where ultrasound is handheld. And you don't get DICOM images that are useful for planning. But what you can really do relatively simply, is that on the day of brachytherapy, you have a CT for CT simulations, right? For planning CT for external beam. I mean, this is a 5-minute scan. When you are out of the operating theater, instead of doing the X-rays, just schedule a scan in CT and do both in parallel. And you can continue planning on 2-dimensional images of conventional radiography like you did, but for transitional period, also look at your CTs and try to contour the organs and see what the dose distribution from your plan would be in actual 3D space. Because I think we need to make a case, because these are curable patients. That's what I've always been saying in the courses many years ago even. These are curative patients. And I mean, if we do CT for brain metastasis, which we usually do, a planning CT, then we should make a planning CT for curable cases of cervical cancer. And maybe if the resources are tight, rather use 2D radiography for brain metastasis, like vice versa. You know, not that one patient is less deserving of the best treatment than the other. Don't get me wrong, because that would be really completely unethical. But if the resources are tight, then we may make such decisions, and sometimes we don't do the change because it's a tradition, and that should not be the reason. The reason should be pragmatic. And I think, for example, for brain metastasis, you can achieve a good plan with 2 X-ray images, or with lateral simulator images. And on the other hand, for brachytherapy, you can achieve much better plan with a CT. That's one idea. And I just wanted to say, when you said 5% using 3D imaging for brachytherapy, I remember 2006, 2007, European or American survey, I'm not sure now, but I think the percentage was exactly the same. 5% of
changed majority of it.
5% of Western European centers and of US centers were using 3D imaging, and 95% were using 2D radiography for brachytherapy of cervical cancer planning. Nowadays, the ratio is quite different. I'm not aware of the actual accurate numbers, but it's likely 57, more than 70% using 3D. And so, I mean, you get there, and it's a lot about pragmatism.
Yeah.
It's a lot about of giving this message to your hospital leadership that it's a very, very big health gain for the entire country. Less so better results, less recurrences, less busy wards, less money for palliative cases that recur, and so on. And actually,
Primož, can you actually mention what the outcome differences are?
the outcome differences.
So
Yes,
2D versus 3D, and now there's MR on top of that.
Yeah, the outcome differences are quite amazing. The outcome differences are such that recently, those of you who have followed ASCO, maybe you saw how pancreatic cancer has seen some revolution with the new immunotherapy that improves survival. And I think now the median survival is 20 months, or before it was 12 or something like that. So it's a big difference, but it's still 20 months. Standing ovations. So that was pancreatic cancer. Now, if the embrace principles would get, let's say, fair treatment, there would be standing ovations, because in cervix cancer, the move from 2D to 3D has improved survival not for 20 months, not for 10 months or 20 months. It has improved survival in big tumors, 3B, 2B, 4A, from poor results ranging from 20 to 50% local control in the old days to nowadays 90%, irrespective of stage, because we adapt to the target and we give more to the big targets because we see them, less to the small targets because they don't need more. So we have more cured patients with less side effects, and the difference is deserving of much more than just standing ovation. But interestingly, because
standing ovation.
No standing ovation because there's no pharma behind, and that's the reason. There's nobody pushing those immunotherapy drugs, making the money, and we are the lone soldiers, you and we all together, and we just need to be innovative, and we need to recognize those reasons for a standing ovations when there is one.
Yes.
And embrace such therapies, and that's such a therapy. Image-guided brachytherapy is such a therapy that makes such a big difference, and it's also cost-effective. which has been proven. It is gaining life years, quality adjusted life years at net cost.
Primoz, what would you say to departments that do not actually have dedicated CT scanner in their department? So they're using diagnostic CT in their hospital, and they also have to move the patient to the ward for HDR treatment. Like, what would be your solution and recommendation?
I would say it's going to be a difficult start, but if you want to make a difference, you can. I will give you my personal story. When we started in Ljubljana in 2006 and 7, before we were doing x-rays and they were in room. So I would do the application x-rays like Dr. Burak now explained, and it was useful, it was working, it was great. But then we said, let's try CT and MRI. There was, of course, no possibility. And what I did was I sat with the patient in the ambulance car and I took her to another hospital to do an MRI.
Okay.
And then we came back with the same ambulance car back to the ward. And this is how we started. And then this gained a lot of attention from the hospital leadership people. And they said, okay, this is recognizable and there is some evidence behind this. And you can do it. I mean, probably it's a bit extreme to sit in the ambulance and travel to a different hospital to do an MRI or a CT. But if the radiology is next door, you can push the table, you can push the patient, and brachytherapy patient is an excellent candidate for that because you don't have to position the patient like you have to position the patient for external beam. You can image the patient standing up theoretically, yeah, because your frame of reference is the applicator, not the lasers and the outer frame.
Yeah. Thank you. We do have a question for Dr. Burak. Thank you very much for your great presentation. What would be your recommendation for pain management before the procedure and for anesthesia for the procedure?
Can I answer Ukrainian?
Yes. Yes.
Оскільки ми використовуємо поки що класичну брахітерапію, то, напевно, в звиклому щоденній рутинній роботі ми скористуємося нестероїдними протизапальними препаратами і якимись місцевими знеболюючими або ультракаїнами, або місцевими гелями для знеболення. Звичайно, краще запрошувати анестезіолога, але в наших умовах зараз це є досить складно. Хоча коли стартує, зараз у нас відбудеться встановлення нового апарату і ми перейдемо на нове джерело, то я думаю, що ми будемо використовувати анестезіологічне забезпечення, таке як поки що використовуємо місцеві анестетики і нестероїдні протизапальні препарати.
Dr. Burak, you also are running the research study, right, for using pain management?
Ми чекаємо на встановлення апарату і тоді вже будемо приєднуватися до дослідження.
Very nice, good job.
Дякую.
We do have another question. So thank you very much for a great presentation, Dr. Burak. A lot of appreciation for Professor Primoz and Christian for organizing this course, for their professional assistance. The question is that do you have any information how frequent is 2D planning through the whole world nowadays? In a ward, how frequent is 2D planning?
In the world, Primoz or Christian, if you have any.
Christian, do you want to say?
Yeah, I think it's very heterogeneous. If we talk about Western Europe, I think centers doing 2D planning is extremely low, very low. Because why? Because the equipment, the extra equipment of having an X-ray unit, and this time you need to reconstruct. As I said, this is more time consuming and more costly as just to use a CT which you already have in your department. So as almost all centers in Western Europe have a CT in the department, they use this CT. I think things are a little bit different in other parts of the world. I know especially the situation in Asia, but also there we have quite the heterogeneity. I think India has become one of the countries where we have the fastest developments seen in the past 10 to 15 years, with really a lot of centers who's transitioned from 2D to CT, and CT is a state of the art in India nowadays. And the same is in some countries like in Thailand. But of course, you have many other countries where you have no 2D planning, where you have only as atlas-based planning, what was mentioned before, just one standard without any image at all. I think we have a situation that 2D planning is diminishing. I think we have more the situation of really centers which are doing no plans at all, just one plan fits all without imaging. And then the other big part, of course, is CT. MRI, to be honest, is a smaller proportion at the moment, but also MRI is coming up in many countries. You have to imagine we have centers in Asia, and they have proton devices now. So why should they do then a T2 plan? They also switch to Linux, and I think it will be the same as an external beam. Primož, do you have exact numbers?
I do not have exact numbers, but I think it's just like you said, very heterogeneous, even within continents. And I was just wondering, I remember that for Ukraine, we saw these numbers. Lesia and Natalia, you provided in the beginning a survey, or some results from a past survey in Ukraine, across Ukraine. And maybe you could tell us how many centers in Ukraine approximately have a planning CT inside inside the department for external beam?
Oh, we know that 13 centers in Ukraine do not have a dedicated CT inside the department. So that's still
Okay.
an issue.
And it's about 30 centers, right? 35 or something.
Right, yeah. And I think Serhi also has all the data. He conducted the survey actually.
You conducted the survey. Okay.
Yeah.
Well, we didn't ask about that specifically, but I think that yes.
Maybe next survey we'll ask that specific question.
That's right.
So maybe in summary, I could say wherever you have a planning CT in the department, try to go this way, and do not allow brachytherapy to be pushed out of the planning CT, and don't accept that they force you, let's say, if I use a bad word, to use just 2D radiography. But of course, if the department does not have a planning CT, then doing 2D brachytherapy is a necessity. And maybe you could then plan in the future, once the planning CT does arrive, to switch to planning CT. That would be our recommendation, of course, all in frames of availability and common sense.
I have one question I saw now from Dr. Burak. You mentioned that your fractionation is mainly following 5 fractions. I assume these are 5 individual insertions. Is this some kind of standard in the Ukraine, or do you have also heterogeneous fractionations there? Because, for instance, 5 fractions within the EMBRACE study is completely gone. We have no center doing more than 4 fractions anymore. Most centers do it with 3 to 4 fractions. Of course, you have to be careful, because if you have less fractions, you have to be more precise. But just another thing, if you switch to CT, you could reduce certainly from 5 fractions to 4, for smaller tumors even to 3 fractions. So this could save you a lot of time in the end.
That's a good incentive. That's a good comment.
Thank you for question, but for brachytherapy we use cobalt-60, not iridium. And when we do planning, we cannot 7 gray for
One fraction.
one fraction. We can only 6 gray or 5.5. It's
Why? Because cobalt-60 is completely identical to iridium-192. The dose distributions look completely comparable.
Yes, but those distributions for bladder and rectum is more than iridium.
That's very new for me. I
No?
even know that it's that when you have the same dose to point A,
Yes,
iridium and cobalt, you have less dose to the organs with cobalt. Cobalt is even a little bit better.
yes, but when we have recommendation and we have a planning system and we do brachytherapy with when we when we give 7 gray, we get more dose for bladder, and
Yeah,
It
which
looks
is
like they cannot meet the constraints, right?
which is true because it's just simply bigger dose, but this would be the same with iridium. It's not a cobalt specific thing, and with CT you could avoid higher dose because you would be able to optimize. Well, really, it's all in the. I'm very happy to say that it's all in the Brachythera curriculum. All those lectures that are there, they do give insights into this. And I think what Kristen is saying, if you move from 5x5 or 5x4 or whatever to 4x6 or 7, I don't know, or 3x7, you will be able to carve the dose, shape the dose better, and actually get less to the organs at risk, even with cobalt, because cobalt will not have some specific less favorable distribution than iridium.
yes.
Thank you very much. I do think we have one more question from Oksana Didic. If you would like to ask, you can ask your question, and then we have to move to the second section of our lecture today. You can turn on your mic and ask your question if you have one. If not, then yes.
No.
Thank you. Then our second section of the lecture today is question to radiation oncologist and medical physicist. So as you already know, we have today our Brachythera experts, who is Primož Petric and Christian Kiritis. Primož is the founder of Brachythera and the program director of Brachythera. And he is radiation oncologist at Cantonal Hospital in Lucerne, Switzerland, and associated professor at the Aarhus University of Hospital in Denmark. He is a teacher of ISTRO, IEA. He is a member of Jack Astor Working Group, Embrace Study Group. He is excellent lecturer, and thank you very much for this course. So Christian is a brachytherapy program director. He is a lead brachytherapy physicist at Department of Radiation Oncology at Comprehensive Cancer Center and Medical University of Vienna. He is co-author on more than 150 peer-reviewed articles and made numerous contributions to conferences, proceedings, and book editor as invited speakers to international conferences. He is also chairman of Jack Astor Committee, faculty member of ISTRO Group of Gynecological Cancer. He is a coordinator of the Committee for ICRU 98 report. Thank you very much for your expertise. We do have several questions, but I would like to start with one for radiation oncologists. Feel free to comment both to any questions that you see. So our first question is, so does the break between external beam and brachytherapy during definitive radiation therapy for inoperable cervical cancer affect the results of the treatment?
Yes, I think this is a question for me, correct?
Yes.
I would like to share my screen because I did find the time today in the morning to put some slides together, if I may. Now, sure. I'm not allowed yet. You have to give me the permission. Okay, now it's working. Okay, so I hope this works. Do you see my slide?
Yes.
Yes, we can.
Okay. Perfect. So your question was, does break between external beam radiotherapy and brachytherapy during definitive radiation therapy for inoperable cervical cancer affect the results of treatment? And the answer is yes. I'll just shortly go through this. So this is a typical regimen of radiotherapy for cervical cancer in weeks 1 to 5. We give external beam radiotherapy, in this case, 25 fractions, which is the most common schedule probably in Europe, 25 times 1.8. Weekly cisplatin, as you can see, the chemotherapy signs. And then in weeks 6 and 7, we may then add brachytherapy, or we should add brachytherapy. There could be differences in this schedule, but it's a typical one, let's say. That would be an embrace type regimen. And as you can see, between week 5 and 6, there is no break. We proceed immediately after external beam to brachytherapy. Why? Because we know that the overall treatment time, and this is a table from a study based on embrace data from 2016, you can see that the overall treatment time, the OTT at the bottom of this table, was, in addition to the volume of high-risk CTV and D90 of the high-risk CTV, the most important factor on multivariate analysis for treatment outcome. So it was very important, it mattered a lot if the patient had treatments that lasted more or less than 50 days. And you can read this in the discussion of this paper, that an increase based on this data of overall treatment time by 1 week was equivalent to a CTV D90 decrease of 5 gray, resulting in a local control decrease, by different percentage based on how big the tumor was. In other words, increasing the overall treatment time means you are losing the dose that you are giving, that you will lose 5 gray per week. So remember this number. This is approximately 0.7 gray per day. So if you have a week between external beam and brachy, you lost 5 gray. And if you give this patient, let's say, now let's go to point A, just an example. If you gave to point A 85 gray of your dose, it is actually 80 gray, because the 5 gray were lost because of the 1 week break. And that was also confirmed in another publication on similar data, more recent one, published in 2022 or 3, by Max Schmidt and Embrace Group. And here you can see the same. The overall treatment time in days was, in addition to the D90 for the high-risk CTV, the most important prognostic factor, which means that time is dose. I will not go in detail with this slide, but time is dose. So keep it below 50 days. That would be my short answer. That would be the first question. Serhii, I can go straight to the second one, if that's okay.
Yes, sure.
Okay.
So
there is one question from Leslie.
Or is there any comments or questions?
Primoz, there is. Look.
So I can continue with this.
Sorry, Primoz, one quick question. But in case if we need to boost our lymph nodes, and in this case, we will expand our treatment time for a week or even for 2 weeks, how we can manage with this?
Thanks. It's a great question. And this is the problem when I try to answer quickly to save time, because I cannot insert all the nuances of the clinical reality in such an answer. And there is many more reasons that we sometimes end up in prolonging treatment times. But for your particular question, there is a solution, because we can boost the lymph nodes as simultaneous integrated boost. If you are using IMRT VMAT, you can boost the nodes simultaneously and apply all the dose within those 25 days. If you are using sequential boost, you could use sequential boost in weeks 6 and 7. Let me go one slide back. So here we have week 6 and 7 reserved for brachytherapy, but there is no reason not to give sequential boost on the same days as brachytherapy. There's absolutely no reason. You are treating if you can organize, of course, your schedule. Clinical routine is sometimes busy, and this may be a big reason against it, but biologically, you can do both. You can do both together. You can do brachytherapy on Monday and Tuesday, and then 3 days boost until Friday. And then next week, brachytherapy, and then 3 days boost. And you gained 6 days of boost, and you still finished within 50 days.
Yes, thank you very much.
Yeah, so that's an idea. And sometimes the patient will have neutropenia, thrombocytopenia, cannot go to operating theater. Of course, there you have no other option. Then you have to wait, because that's a higher force, and you have to accept it. But you might consider then adding a little bit of dose to compensate for the lost time, which means lost dose.
Okay.
All right?
Okay, thank you very much.
Okay, then we go to the second question. Postoperative radiation therapy for cervical cancer in the presence of risk factors. In what cases should additional brachytherapy be used after external radiation therapy? What regimens are recommended? So this is a question that is not addressing the topic, actually, the locally advanced cervical cancer directly, but it is an important question, and it's a recurring question. That's why I took some time to find some slides, and I actually borrowed them from a recent presentation that I was lucky to attend in ESGO 26, presented by Professor Cibula David from ESGO, who is the first author of recommendations of the ESGO-ESTRO recommendations on cervical cancer. And if you open those recommendations, updated in 2023, you will see that in some tumors, some cervical cancer tumors, if you have a combination of negative prognostic factors, you may consider radiotherapy, and in rare cases, observation. Which are these negative prognostic factors? This is tumor size. Let's look at them. Tumor size, depth of stromal invasion, and low lymphovascular invasion. In terms of tumor size, there is no cutoff, but typically 2 to 4 centimeters. Tumors larger than 2 centimeters, tumors invading more than 2/3 of cervical stroma, and tumors having lymphovascular invasion. If there is one or two of those factors, you could consider then adding radiotherapy. There is no question when you have this high-risk patient, the other group, where you have parametrial invasion, positive vaginal margins, or nodal invasion, that you do give radiotherapy in any case, even combine it with chemo. But in these cases, intermediate risk, this is a much more gray area. What we do typically, classically, is we use those typical SEDLIS criteria. We all are aware of this SEDLIS study, which was a randomized trial that compared no adjuvant treatment versus adjuvant radiotherapy without chemotherapy in patients who had more than 1/3 of stromal invasion or LVSI or large tumor. I think it was 2 centimeters cutoff, but I'm not quite sure actually. And what it showed is that survival was better in patients receiving adjuvant radiotherapy. Now you need to remember this is 1993 or 1990s, published in 1999. So old technique in terms of surgery and radiotherapy. And that's why also the survival that we see here, the progression-free survival, is not as good as we see now. Now, as Professor also mentioned here in his presentation, very poor local control in surgical arm. So, to answer, do we have to do this radiotherapy in such cases or not? They performed a comparison from 3 institutions. One was from Prague, the second one was from Memorial Sloan Kettering, and the third one from Melbourne. And they pooled all those patients together. They had LVSI, deep stromal invasion, or LVSI and tumor size more than 2 centimeters, or tumor size more than 4 centimeters. So this is answering your questions, how would you choose patients for adjuvant radiotherapy? There is no clear, it's either one of those or combination of more factors. And these surgeons and radiation oncologists in this study, they were postulating that if surgery is good, you actually don't need radiotherapy in such cases. And actually they showed that this is true. So the old SEDLIS criteria, they've proven they're not valid if you do surgery well. And here you can see that surgery-only group in red line, in gray line, was the same as the control group, which was the SEDLIS type treatment, surgery plus radiotherapy. So radiotherapy added nothing, just morbidity. And then there was a whole list of studies that showed the same. Survival was not improved after adjuvant radiotherapy. So it's very questionable if this old Sedlis criteria, tumor size of 2 to 4 centimeters, lymphovascular invasion, deep stromal invasion, are needed at all. Another study here from National Cancer Database showing that adding adjuvant radiotherapy added no benefit, like in that comparison from Prague, Memorial, and Melbourne. Another study or meta-analysis of 11 studies showing no benefit of adding radiotherapy according to Sedlis criteria. Another study, population-based registry from the Nordic countries, almost 1,000 patients, modern surgery, modern radiotherapy, no benefit of adding radiotherapy in Sedlis patients. Another study showing the same. And here, this slide is not quite in the same flow, but what it shows is that adding chemotherapy, this is a study that was performed recently and showed last year at GOG, at ESGO, that adding chemotherapy was in particular not needed in such Sedlis patients. So if we do anything, we would give radiotherapy but not add chemotherapy to patients that have this lymphovascular invasion, deep stromal invasion, or large tumors. So my answer is, your question was, which patients? I would tell you, I don't know, because it really depends on how your surgeons do your surgery. And if you have very confident surgeons that just think that they do excellent surgery, but they actually don't, then not adding radiotherapy and relying on the results from Memorial, from Prague, from top surgical centers, you may harm your patients if you don't add radiotherapy. And that's why a Cervantes trial has been started, and this will be recruiting now. And they will invite centers that do good surgery, and they will ask this question in a randomized fashion among different centers. So with good surgery, is additional radiotherapy needed or not? But for conclusion, you should, according to current guidelines, add adjuvant radiotherapy to surgery whenever you have deep stromal invasion, more than 1/3, lymphovascular invasion, and or large tumor. One additional factor is if the histology is adenocarcinoma, that could also tilt your decision towards additional radiotherapy. So with all these excellent results of surgery that just simply doesn't need additional radiotherapy, we still have to be careful because not all surgeons are excellent. Just like all radiation oncologists are not excellent, and that's a reality. And I mean, we are constrained by some technical limitations, and we should take this into account. So it really has to be a local decision what you will do. Questions on this one? Or comments? Or was I clear? I hope I was clear.
Yes, it's very clear and supported by many studies. So thank you.
No, that was because of Professor Cibula, not because of me. I stole his from his video today.
Thank you.
Okay, good. Then I have a third question. In what cases is the treatment of cervical cancer is it initially desirable to carry out courses of chemotherapy followed by radiation therapy? The size of the primary tumor spread to vagina or bladder invasion? And I added the final question here: where do you prescribe concomitant immunotherapy for cervical patients? Because I think these questions could be answered maybe together. Now, this is the Interlace trial. We know that in Interlace trial, induction chemotherapy improved progression-free and overall survival, and that improvement at 5 years was significant, 73 versus 64% for progression-free, 80% versus 72 for overall survival. So it's quite a big improvement. The world went crazy and started giving induction chemotherapy to all patients. But you need to know that Interlace patients were actually not that high risk. There were T1 to 3 and 0 to 1. There was no patients with para-aortic disease. And there were no really big, large tumors. And and only one center, I think, from maybe middle income country, where you could say there are longer wait times for radiotherapy, and you need some bridging in terms of waiting for radiotherapy to buy some time, and then during this wait time you give induction chemotherapy. So this trial can be criticized in so many ways, and I take every opportunity I have to criticize it openly. And we also published recently in the Lancet Oncology, or in the Lancet actually, a letter of the Embrace group giving our opinion, and you can look this up. I think there is even no, I didn't put the citation on at the top of this slide, but maybe you can find it. It's commentary on interlace in Lancet. Now, if you look at this, it looks great. So why don't we give chemotherapy to all? Because if you do Embrace type 3D image-guided adaptive brachytherapy and good external beam, and if you treat Embrace 2 Inter-like patients, so the patients that have similar characteristics that the ones that were inside the Interlace trial, T124 and 021, no para-aortic nodes, then you will see that the results in Embrace 2 for such a subgroup of patients were actually, for progression-free survival, slightly superior to neoadjuvant group inside the Interlace trial. And for for overall survival, even more so. So using good radiotherapy compensates for giving chemotherapy. It's cheaper, it's better in terms of outcomes, it is less heavy for the patients, less side effects. And the reason why the results are so much better is hidden in this pie chart here, probably because in Interlace trial, 70% of centers were using 2D brachytherapy, and probably the induction chemotherapy just compensated for the poor results of the 2D brachytherapy. So 3D, my answer would be, first ask yourselves, can I improve radiotherapy and bring this to a certain standard? And then on top of that, add induction chemotherapy. But I should not have such a pie chart and then add induction chemotherapy to compensate for suboptimal radiotherapy.
Primož, can they do subgroup analysis and just look at 2D versus 3D?
They can't, it's too small, and it was not pre-planned.
Okay.
It's too small. That's just 500 patients in, and it did not show anything. And also, I must say, this 30% of image guided was not really Embrace type. They did some volumetric type of planning, but it was not really Embrace type. So, in summary, I would suggest work on improving the radiotherapy techniques, and keep in mind that there are patients that will benefit. So maybe this 76 and 85% can be even better if you add induction chemotherapy, but for well-selected patients. And this is what you actually asked. Which patients? I would say patients with very big tumors that cannot start with immediate feasible chemoradiation. Otherwise, it's not worthwhile postponing an early start of chemoradiation. Not worthwhile waiting 6 weeks to give induction chemo and start with chemoradiation later. But in patients that have such a big volume or are very high risk, have large, many para-aortic lymph nodes, there are no clear standards. If Interlace trial was done a little bit smarter, they could have answered those questions, but we still don't have the answers. Probably these are patients with a lot of tumor load that will benefit from induction chemotherapy. And for the keynote, for the pembrolizumab being added to chemoradiation, it's actually similar. If you take Embrace 2 keynote-like patients, which are high risk, T3 to 4 NEN and T1 to 2 N1, and para-aortic nodal disease, you see that with pembrolizumab, it's moving automatically. In pembrolizumab, you can see progression-free survival was better in the keynote study than placebo, and overall survival was also better than placebo. But Embrace 2 patients that have similar characteristics as keynote, again, good chemoradiation single-handedly does better job than suboptimal chemoradiation plus very expensive immunotherapy. So I would say, again, similar question, answer to your question. First, work on improving chemoradiation. Then ask yourselves which patients can have additional benefit. And probably these are those high-risk patients. I would be much more permissive in terms of when to use pembrolizumab. It probably brings much more to carefully selected patients, while induction chemotherapy probably does not bring much. So I would use induction chemotherapy very rarely, unless you really have a big problem with wait times. And you have a patient that has to start, and you know that she either waits at home for 6 weeks before she starts chemoradiation, or in these 6 weeks she receives chemotherapy. That could be a good argument. With this, I come to the end, and the last question: do you use transposition of the ovaries before the definitive radiotherapy of cervical cancer? But maybe I think I took too much time with the previous questions, so I'll leave this to Christian now. Otherwise, it will be too long, and maybe we can leave it for the next time.
No, I think we have time to answer it.
Okay, so it's a complex question, and I don't have any slides. I was hoping you would.
We can leave it. We can leave it for next time. So
I was hoping you will buy my bluff and you will say okay.
yeah. Let's do that.
Thank you very much.
Let's do,
Yep.
and then maybe a few
But
questions.
it's a complex question.
If you can stay still.
Yeah, it's a complex question. It's a complex answer, but maybe we can keep it for the next time. Yeah.
Sounds good. Yeah.
Thank you.
Christian, can you stay a little bit longer to answer questions?
And now Primoz, he prepared slides. This was, of course, a little bit shock for me because I have not prepared slides, but I used the time when he gave his answers to prepare some slides.
Oh,
Okay. So you can share then your screen, please.
You
Then I
didn't
can
have
also
to
share
prepare
my screen.
slides. It's going above and beyond.
I had to when Primoz is doing this. So can you see my
Yeah,
slides
perfect.
now already? So the first question was what practical criteria do you use when it's sufficient or when not? And I think this fits also very much with the second question. If I consider orthogonal X-ray verification sufficient, or should we use CT or MRI? I think I would like to combine both questions. What we have is when we have a situation like this, and I think it was already mentioned by our colleague Dr. Burak before, this old type point A based technique is not that bad. In those cases, we have a situation where our target volume is also approximately just 2 centimeters to the left and 2 centimeters to the right of the tendon. So I think for such small cases, for just covering the target, you are not getting any information from radiographs at all. You can just treat them with an atlas-based technique. I mean, this is a very clear thing. However, we often have a situation where an infiltration is present, where we have on the left side not 2 centimeters, but more 3 centimeters. And on the right side, 2 centimeters, asymmetric situations or very large tumors. And then, of course, for such cases, this point A-based technique is not sufficient anymore because the point will not give us a good estimation of the dose. And of course, the problem is when we have a radiograph, we see actually nothing. We see the applicator. This was already shown before. The points are somewhere. And when we have information about the target, and of course, I'm showing now something very sophisticated MRI-based techniques, we suddenly see how the tumor looks like.
I'm sorry. Do you have two screens? Because maybe you are showing on another screen.
You should have said this before already. What have you seen the whole time? What have you seen? You saw
the first slide. We just saw the first slide.
There was an animation behind. I wanted to show you actually this. Do you see this here now?
Yes. Yes, we
The
see.
animation is not working for whatever. So what I wanted to show is actually that the red one is the situation when we have a tumor which is just linked to the which is 4 centimeters in width, while the blue situation is something different. We cannot cover this. And then I wanted to show with a very nice animation. I'm so sorry this didn't work. I wanted to show that this is the radiograph. We see almost nothing. And of course, if we have information from an MRI, we can clearly see how the situation looks like. And this is, of course, this is a big benefit because we can also do optimization. We can increase the dose distribution. We can shape it just to one side, for instance. This is, of course, one step further with an additional needle here. So in all those cases where we have more than 4 centimeters in width, definitely we would need to switch. I think you could maybe also think about to have very small tumors done with the approach you're doing now, and for larger tumors, try to do it with CT. And if you go to the ICU report 89, I have already told you there is a specific chapter on radiograph dose assessment there. And in this chapter, you could find a lot of things. For instance, this graph is from this chapter. It again shows you if you're able from clinical examination or from pre-treatment CT, or pre-treatment MRI, or whatever, to estimate how the dimensions look like. So on the left side, you have again a situation where the target is limited to the cervix. The tumor is not infiltrating. The tumor is just inside the cervix. You know the cervix is 4 centimeters in width. Then you can maybe use point A based technique. Here on the left side, you know, the tumor is going more to the patient's right side. Then I can try to shift. I can use the ovoid on the right a little bit more, the ring on the left, on the right side a little bit more to shape this. And this is, I think, for the situational target. It's a little bit different if we come to the organs at risk, because for the organs at risk, and I make this a little bit larger, I'm so sorry my animation is not working. Do you see these yellow stars here? These yellow stars, actually, these are those points which are defined in ICU 38 already, but still in ICU 89. The bladder dose point, the rectum dose point. But of course, you see here on the left side, it could be that the situation is as follows. The anti-uterus is shifted a little bit more cranial. We have a very high dose to the bladder here up, but you will not detect this high dose when just looking on radiographs. CT, you could see it have this high dose. So actually, these are points, but there is also this level 1 reporting now, and this level 1 reporting from ICU 89 would have a point A dose, a rectovaginal point, and of course, if you have a CT, to have at least this most exposed DVH volume parameters, 2 cubic centimeters for bladder and rectum. If you don't have CT, then at least try to look at your bladder reference points for radiographs. So this is actually my message to that. And to be a little bit faster, the second question.
Christian, can I ask you a question before?
Yes.
Just to explain, perhaps if you can, because sometimes we get this question, and maybe some people are wondering, how can you plan on MRI? We know MRI is very rarely used even in developed world, but how do you use MRI for treatment planning if you don't have the atomic density or the data needed for those calculations that we usually use for external beam planning?
Yeah, actually, that's a very, very simple answer, and I can also show you maybe another old technique here. This was I have to look it up. But actually, you know my slides pretty much. You know this very old. This is an MRI-based treatment plan, and this is from 2002. And the simple thing is that with iridium and also with cobalt 60, we are in a energy spectrum range where we don't need to know the Hounsfield units. So we can just plan on MRI as we do with CT, as we do with radiographs, because only the distance matters. And then the simple TG43 algorithm, we don't need to know the Hounsfield units on MRI. Any other questions to this? I don't see you now. Are there any other questions to the first two questions here?
Not yet. Just a comment, maybe that the bladder point and rectum point, usually I have been lucky not to work with the 2D image too much, but with the 3D CT images. So I know that in 2D images, bladder point and rectum point usually have a less dose, much less dose than 2 cubic centimeters of in the CT planning. Is there some very rule of thumb or any type of scale what is the critical then point for rectum and bladder when using 2D images?
Is there a magical correlation?
Yes.
There is no magical correlation. I think we were working on this for, I don't know, many years. I think I have here slides now. These are really old. These are from 2002 or 3. No, it was later, 2004. And there we tried to do these magical correlations. You see here, this was some kind of ratios, but the ranges were extremely high. You're right. You're totally right. In principle, the points always are lower than this T2cc point. So there's a factor for bladder of 1.5. I had a factor. But look here, this was my own publication in 2004. On average, it was 0.4, but it had a variation. It could be half, it could be 3 times more. And we really tried a lot. We tried a lot, but we failed. There is no magic correlation. There's on average a magic correlation, but each individual patient is different. Why? Because a patient could be like on the left side, that the applicator is more shifted up, then you are far away from this dose point, but still have a high dose to the bladder. Or it could be like on the right side, the applicator is more down, and then this bladder dose point is more similar to the DVH values. So it will be very different for each individual case. I cannot give you one single number. And we tried a lot. We tried 10 years or more, but we could not find a magical correlation.
Thank you for working 10 years ago for our questions. Thank you.
It's impressive.
3D is the magic, right?
It's impressive how quickly you find the slides, Christian.
Yeah.
That's impressive.
Very impressive. Good job.
I had to prepare, and now I'm very humiliated at the end.
See, thank you. But I have two more questions. I mean, if we can order just a few applicators for now, what should we order? That's a very good question. And I think, Primož, you have to help me now. Of course, it probably differs on your application style. We in Vienna, we also started to always buy the whole set, all kind of angles and everything. And then we found out that we use only a few of them. And I think it depends a little bit what kind of applicator you're using. I think you do very well with just one tandem angle. But maybe you always need to have 2-3 different lengths for the tandem. And for the ovoids, I also think you need maybe at least 2 to 3 different diameters. But certainly you don't need all angles. Primož, would you also agree to that?
Yeah, for sure. Yeah, you maybe it's a good start if your angle is 60 degrees, because that will fit in most of the patients. And if your length, the average length will be 6 centimeters, but sometimes you will need shorter than that in very small uterus. With this, so if you have a 60 degree, 6 and 4 centimeter length, and 2 size of ovoids or 3 size of ovoids and O-ring, I think you are covering pretty much everything. I remember, Lesia, you asked me via WhatsApp about the needles, right? Sharp or blunt, right? Metal or steel?
Yeah, about the needles, because it's the most cost-effective part of interstitial
Very
brachytherapy.
expensive, yeah. It's very expensive.
Yeah.
It depends a little bit on the vendor. Some vendors sell them single use, some sell them for, you can use them 20 times. So it's the most expensive part. It's cheaper if they are metal, if they're steel, but then you cannot do MRI. If they are titanium, you can do MRI based. They are more expensive again because they are titanium. So the most commonly used ones are plastic. And if you use, as you will learn in the Brachythera course, the vaginal templates, which are either ring or ovoids with holes, then you can use blunt needles, not sharp needles, because it's not difficult to puncture through the tumor without the sharp tip. And you can use blunt needles. So the most common combination is a blunt plastic needle with a vaginal template, ring or ovoid with holes for interstitial. If you go transperineally, then you will need sharp needles to puncture the skin, and you will probably need something more rigid than just a simple plastic needle, maybe sometimes because the length is longer and deviations will be bigger. So you will have less deviations with metal needles. So it's a bit a mixture. Every center decides based on experience in the learning phase of a year or two what suits them best. I have most experience with plastic blunt needles. Very safe. You don't go through the bowel. You just push the bowel away. You're not worried during the application if the needle is not sharp.
Okay, but in case of like titanium or metal needles, we can just make a hole in a bowel or bladder, and we need to think about this and how can we avoid this during the procedure.
You can't really avoid it, but you can reduce the chance by using ultrasound and by using patient preparation so that the patient doesn't come bloated. They should receive a proper bowel prep. The bladder should be empty during needle insertion, ideally, so that it does not expand to the area where you are. So if you use full bladder during insertion of the tandem to have the ultrasound probe on the abdomen, for example, then you need to empty the bladder during the insertion of the needles to the vagina so that the path is clear. And ultrasound, intraoperative ultrasound, transrectal in this case, will help you. This is also all in the lectures of the Brachythera course. And as far as titanium needles are concerned, Christian has a lot of experience with titanium. I think they come with blunt tip. So I think titanium is an extra choice, but it's more expensive.
Yes. And what about the lenses? What
Length, 30
lenses?
cm. 30 cm. Because the vagina, if you use vaginal templates, you need the 30 cm needle. Prostate are typically 20, I think. But there the path is not so long. With 20 and vagina, you will spend 10 centimeters of the needle just to reach the fornix. And there's not much left in your hand and to attach to the afterloader at the end. So 30.
Thank you very much.
So for the first time we have pretty much we are using 24 centimeter needles in always.
All right.
I think 24 also fits fine. But you're right, of course, if it's longer, it's a little bit easier. 20 definitely is too short, but it depends on the vendor. So the 24 or 30, yes.
Yeah, Varian has 30, that's why I use 30.
That's why. And Elector has 24, and what 24 works. Then very quick one. The other question was, the last question was, what was the last question? I found another. While Primoz was talking, I was again looking into some very old. And look here what I found here. There was a case Do you see this already? I can only zoom
we
it
can
here.
see it. Mhm.
Yeah, this was a case treated very early, and our ICU point was 80 gray. 80 gray is fine, but she had a grade 4, and the situation was that when we looked on MRI or CT, whatever you do, we find out that the T2cc was not 80 gray, but it was 140 gray, because it was a situation like here. This is, I think, exactly what he said before, that with those points you can very, very much underestimate, because you don't see that much. You just see something very rough and not really any organ contour. Yeah, and the last question actually I got was,
Would you
what
like me
was
to
the
read
last?
it? So
Yeah,
in
it
a
was.
low resource settings,
Yeah.
what?
Yeah.
Yeah.
Thank you. I found it here. Yeah, and I just marked it in yellow actually because it's a very tricky question. But I'm a big fan of advanced imaging, and advanced doesn't mean necessarily MRI, but a CT is of course a big advancement, and I think this is really an eye-opening. Maybe you, even as Primož said, in the beginning you don't use it to really digitize the applicator, but you just make an advanced image, maybe for the first fraction at least only, to see how the situation looks like, how the organs for this specific case look like, and then you can already have an idea about the bladder situation, the rectum situation. I think I would start with imaging, and then trying to do some simple optimization, not too much. Simple optimization means a little bit larger, a little bit smaller, a little bit more to the right or left. I think this would be probably the first steps. And then, of course, you have to go into applicator verification, contouring, and QA as well. But I would pick those two.
Thank you very much. Thank you very much for a very interesting presentation by Dr. Burak. Thank you very much for excellent answers to the question. With your experience, with support from the literature, that was very comprehensive, and to me it was very much convincing that the answers are like so solid. I should say. We will have more time on the next lecture to answer some more questions. We very much appreciate your time. We are quite over time actually, but that was no regrets and many appreciation to your time and to your expertise. So the next lecture actually will be on the 1st of July, if I'm not mistaken, and it will be image-guided brachytherapy. So stay tuned and continue with your study. Всім доброго вечора.
Доброго вечора. Дякуємо всім.
Доброго вечора.
Доброго вечора.
До побачення.
Дуже дякуємо.
Дякуємо.
Thank you,
До
Primož.
побачення.
You're welcome.